This is Michael from Blue Sky Bio. I'd like to thank everybody who's joining us for the third presentation in this guided surgical series. As always, please make sure to enter your details in the webinar attendance form. The link can be found in the comment section below the video screen. If you have any questions during the presentation, please enter them into the QA box to the right of the presentation screen. Today we're going to be hearing from Dr. Rick Ferguson. He's an international speaker and educator, the founder and owner of Implant Educators, and has trained thousands of doctors. Recently, through his contribution to Blue Sky Plan and research on 3D printing, he's taken monumental steps to help bring guided surgery to your practice by making it much more accessible and affordable. The Ferguson technique is going to be implemented in the next release of the Blue Sky Plan software. And to tell you all about that and everything that's going on, here's Dr. Ferguson.
Well, thank you very much, Michael. First of all, I'd like to thank Blue Sky for giving me this opportunity to present on some of the work we've been doing in our practice, using 3D printing to fabricate surgical guides in office. And I'll sort of take you a little bit on the journey that I had, how I got to this point. But before I do that, I do want to disclose that none of the products that I'll be discussing today have I received any financial payment for. However, I am, as Michael said, the owner of Implant Educators, and we do run a comprehensive implant continuum. We run it at University of Florida College of Dentistry Clinic in Seminole, Florida. We are now going into our 10th year of running this program. It's a phenomenal program, and I highly recommend anybody who wants to get additional training in implant dentistry to come and take our program. So this program is quite unique because we're able to bring dentists from any U.S. state, any U.S. licensed dentist, and they can place implants and do procedures under our supervision. These are some of the cases, for example, that some of our students performed in the last year. We teach implant placement, bone grafting, sinus grafting, tenting procedures. Any aspect of implant dentistry that you want to get more experience with, we can bring you down to Florida, and with our team of speakers, we can train you in all aspects of implant dentistry. As you can see, we have a complete team of both general dentists and specialists who are committed to your excellence in implant dentistry. Of course, one of the things I'm very proud of is our private practice. We do have a private practice. This is myself and my wife, Dr. Katherine Ferguson. We have a small office in Davie, Florida, which is near Fort Lauderdale. And pretty much everything that I'm going to be talking about today, we've developed in this practice. So before we talk about 3D printing and guided surgery, it's important to understand that most dentists are still using 2D x-rays to place implants. And to me, that's unfortunate because 2D x-rays do have limitations. You know, there's incorrect measurements, distortions, positioning errors, and of course, overlying anatomy. So in our comprehensive implant training program, we only use three-dimensional imaging for all of our implant planning. And that's based on a recommendation by the American Association of Oral Maxillofacial Radiologists. You can see here we're actually going through a case that we're going to be doing later that day. And here I am supervising a student who's placing an implant. And here's my colleague, Dr. Arthur Acker, supervising another surgery. But there are also limitations to 3D planning. Not only do we have to do the plan in 3D, we have to transfer that plan to the patient. So in essence, we need to go from virtual reality back to reality. And sometimes we can lose direction if we don't have a guide, as was the case with this doctor. Here's a situation where a dentist had planned the case out on his CBCT image. He was drilling the site to place an implant and perforated through the lingual cortical plate, stopped the procedure and picked up the phone and called me to find out what to do. Now, one of the worst things that can happen in implant dentistry is that we perforate the lingual cortical plate in the mandible and injure the lingual artery and have a bleeding situation. That did not happen here, luckily for the patient and the doctor, but it just illustrates that not just planning the case in 3 dimensions is important, but we also have to execute the case. Here's another situation that was brought to me by a dentist at a meeting who came up and asked me what he should do. He had placed 2 implants, and the patient ended up with a numb lip. He came to me and asked, well, what should I do at this point? I told him, first thing you should do is probably take the implants out, which he did. He then sent the patient over to our office for a CBCT image, and we could see on the CBCT image where he had perforated the inferior alveolar canal, either with the implant or with the drill. Interestingly, also, this doctor had also placed planned the implant placement on a CBCT image, but he didn't execute it on a CBCT image. Here's another situation that is far too common. This x-ray was sent to me by a colleague who does not place his own implants. He had referred the patient out to a surgical specialist to have an implant placed. The patient came back now to have the implant restored, and as you can see on this image here, that the implant is not in the correct position. It's actually too far distal within this mesiodistally within the restorative space. So he wanted to know what the possibilities were to fix the situation. He called the surgical specialist, and the specialist said, well, it's simple, just change the crown on behind the implant to create more restorative space. The problem is that the tooth behind the implant was also an implant, and that would have meant doing a new abutment and a new crown. And the question is, who's going to pay for that? In my opinion, this case really needs to have the implant removed and placed in a better position. And obviously it was not placed with a surgical guide. So that brings us to guided surgery. And I'm going to start off showing this case of Rita. Rita is a 60-year-old Caucasian female who came to us, to our practice, as a second opinion. She had had a full arch of dentistry done 1 year previously. And you can see that the implants have started to break down. There's some bone loss around the implants, and also the teeth have decayed. Remember, this case is only 1 year old. So Rita came to us as a second opinion. We sort of have a reputation in the South Florida community as a place to go to have your implants fixed, unfortunately for us. But we certainly wanted to help Rita out. So this is what we found. The bridge was actually very loose. And the dentist had tried to reconstruct an entire arch of teeth on 3 implants and 2 not very stable teeth. Our plan for Rita was to extract all of the maxillary teeth, place bone grafts, place her in a full denture, and 4 months later, do a CBCT and guided surgery for placement of 6 implants for a fixed hybrid, and then fabrication of the hybrid 4 months later. Because of Rita's previous experience, we didn't want to take any chances and try to do anything immediate for her. Finances were also a consideration, so we decided to proceed in a stepwise fashion. So the first thing we did was to take out the teeth, take out all the implants that were losing bone. We grafted the sites, and then we planned in software using the denture as our guide, placement of 6 implants perfectly paralleled, and we had a scan appliance made and converted that to a guide at a cost of about $950, not including the cost of the CT scan. And then we executed the case. You can see it went very well. Here are 6 implants placed perfectly parallel to each other. Here's a post-op CBCT image immediately after the implants were placed. And here's a subsequent uncovery, placement of multi-unit abutments, and fabrication of a full arch zirconia restoration. And here's the restoration in place. And if you remove the lower teeth, it looks even better. That's a trick speakers sometimes use. And Rita is now fully restored. She's functional, she's happy. And the surgery itself was not the biggest part of this case. The actual surgical placement of the implants took about an hour and a half. You know, using a surgical guide makes it certainly a lot faster and a lot less traumatic for the patient. Rita, by the way, was a dental phobic patient, and we were able to manage that by doing things in a stepwise fashion and providing what I consider one of the best restorations today, long-lasting, with 6 implants that I expect this restoration to last the rest of Rita's life. Now, I did mention that we run a comprehensive implant course, and I wanted to start off with Rita's case because here's another case that was done at our course in the clinic by one of our students. Now you can see it looks very similar to Rita's case. 6 implants for a fixed hybrid. Here's the surgical placement of the implants. A guide was used, very similar to the one that we made for Rita. And here are the implants now ready to be restored several months later. Now the interesting thing about this case is it looks very similar to Rita's case, but I didn't place these implants. These were done by a doctor who had never placed an implant before. This was his very first implant case. He was able to place 6 implants, perfectly placed, all within a time period of about an hour and a half, about the same amount of time as it took me. Of course, he did it under our supervision, but you can see the result was very similar to somebody like myself who has 20 plus years of implant experience. I call guided surgery the great equalizer. Now that doesn't mean that everybody should run out and get a guide and start placing implants. You do need to have a full foundation in implantology, but certainly guided surgery makes it a lot easier for implant placement. Here is his final restoration. He restored the patient in his office. Very similar a restoration to what we had done for Rita. That's the magic of guided surgery. So why don't we do all cases with guides? I would estimate that about 5% of cases done in the United States, implant placement right now, are being done with surgical guides. Very, very small number. Why don't we do all cases with guides? What I hear from doctors who we train and who I speak to at meetings and such is, of course, the cost of the guide, the cost of the software. There's a lab time that's involved. And of course, this makes it very inconvenient as well. Well, we're about to change all that. Now, I first was exposed to in-office guide fabrication at the Florida National Dental Conference in June 2013. At that meeting, there was a doctor who was sponsored by, I believe it was Sirona, who did a live surgery. And he was able to illustrate how to fabricate a surgical guide, how he fabricated a surgical guide in his office. He used that surgical guide to place a single implant in a very short period of time. It took him less than 20 minutes in front of an audience of probably 100 dentists. And it was very impressive to me. I had never seen anything like this, even though I had been involved in implant dentistry for a long time. We had been using surgical guides, certainly, and we knew the advantages of using surgical guides. But what was impressive to me is that all of this was done in office with a very high level of accuracy. So I walked over to the Sirona booth and I told them this was very interesting. I'd like to get involved and see what the cost would be involved with this. Well, they said I had to buy their proprietary CBCT, their intraoral optical scanner, their mill, because it was a milled guide that this doctor had used. And we had to also purchase additional software, which is a proprietary closed software. When we added up everything, it came out to be about $330,000. Wow, that's quite a bit of money. I could see why, you know, a lot of general practitioners, especially, you know, brisk at the thought of spending this kind of money to get involved with implant dentistry, especially guided surgery. But I decided to go on a journey and try to figure out why this technology was so expensive, first of all, and how we could reduce the cost of in-office guide fabrication. And that led me to learning more about DICOM images and STL files. STL files are the files that are produced by optical scanners, and of course DICOM images are the images that are produced by CBCTs. So what we learned through our journey was that we had to figure out how to merge DICOM images with STL files, optical scans. And I was up late one night surfing the internet, and I found an article where there were dentists, a couple of Italian dentists actually, who were doing this in sub-Saharan Africa. And I thought to myself, if they're able to do this in sub-Saharan Africa, at a very low cost, by the way, using consumer level 3D printers, why couldn't we do this in dentistry and help reduce the cost of our surgical guides? They were, of course, making bone models, and that's where we first started. So I went on this journey. I found some companies that had products that were amenable to doing this in office. One of them, of course, was Blue Sky Bio. They're really the only alternative out there for software if you want to do it in office at a reasonable cost. I also found a 3D printer from a company called Cell Robox, which looked very interesting. It was not my first 3D printer. I bought a different 3D printer and started experimenting with it. But what I found with the Robox was the ease of use. I felt like it was something that most dentists could use in their private practices. So with the Robox printer, we started printing guides. And well, we actually started printing models first. I'll show you a couple of cases in a minute. And let me tell you, when I was just amazed by what we were able to do with this. Not only because of the quality of the prints that we're able to achieve, but because of the cost. I call this ridiculously cheap. Here is a screenshot from the software of the Robox printer. This is software that comes with Robox printer that actually does the printing part of it. And you can see where the arrow points here. It shows that it's going to take about an hour and a half to print this surgical guide. This is a quadrant guide. It's going to use 5 grams worth of material, and it's going to cost about 36 cents. When I say ridiculously cheap, I wasn't kidding. So we started, first of all, printing models. We weren't quite sure about surgical guides, and we started printing models. And what was interesting is we found that we could actually reverse engineer a surgical guide by using the model and actually practicing the surgery on the model. Even more interesting, we found that if we took an x-ray of that model, we could actually see the anatomy. Now this takes some changes to the settings on your x-ray head, but if you get the radiation level low enough, you can actually make out the roots of the teeth and the inferior alveolar nerve. So we practiced placing the implant on this plastic model and then reverse engineering the guide, and then taking that guide to the mouth, and here we're just using clear triad gel, and actually using these guides, which could be cold sterilized, and we were able to make a very accurate surgical guide for around $10. Here you can see this is the plan, if you want to call it that. This is the x-ray of the plastic model with the implant placed in it. And here's the actual implant placed using that surgical guide. Now, of course, this type of surgical guide actually did have depth control and angulation control because we're using a guided surgery kit with it. Here's the actual implant placed in the mouth. And we'll move on to another case. Here's another case where we actually use a surgical guide based on a model that was 3D printed. Let me introduce you to Paula. Paula is 16 years old. She's post-orthodontic therapy. She was referred over to me by the orthodontist to have an implant placed in the number 26 position. Well, we took a CBCT and found out that there really wasn't enough space to place the implant. And as a matter of fact, if we place the implant in the correct prosthetic position, you can see that we actually don't have enough buccal bone, even though we have a lot of lingual bone. The trajectory of the implant based on the ideal prosthetics makes the implant a little bit too buccal. So we asked the orthodontist, in Paula's case, to go ahead and give us a little bit more room. We also did a tenting procedure to build up the bone so that we would have enough bone to place the implant. And this is Paula about 4 months later. You can see the orthodontist had opened the space up for us a little bit more so we could get a small implant. This is a 3.0 diameter implant we're planning here. And we had grown some additional bone using a tenting procedure. Now, I am involved in teaching this comprehensive course, and this is a true story of what happened. One Monday morning, I get to the office. It's about 8 o'clock, and I had just come back from a weekend where we were teaching our course. And I look at the schedule, and I see that Paula is on the schedule at 10:30 to have the implant placed in this position. And I had not fabricated a surgical guide. So what we ended up doing for her was actually printing a model that morning. We placed a dummy implant on that model. You can see how we can see the actual roots of the adjacent teeth. We then used clear triad gel with a brass sleeve to do a pickup of the drill in the osteotomy, and relined it on a solid model and fabricated a surgical guide for around $8. Again, ridiculously cheap. But again, this is a model-based guide. So let's see how this worked. Was it really accurate enough for this case, which really, as a 16-year-old kid, we really got to nail this because we want that implant to last as long as possible. And you can see we drilled into the site. Here's the osteotomy prepared. We placed our implant. And here is a post-op scan of our execution of this case. You can see on the left side the actual implant in the patient's bone based on this guide that we had made. And on the right side, you can see the plan that we had actually made on the CBCT. Now, again, this guide was not fabricated based on the computer. It was based on a model that was generated from the CBCT. So this was our first experience using 3D printing. And here's the final restoration, a screw retain restoration, no cement to deal with. You can see it, I think it looks pretty good for Paula's restoration. So let's look at the next step in this evolution, on this journey that we were making. This is Hugh. Hugh had 4 months previously had a tooth extracted, and we had done a socket graft. So using the Blue Sky software now, we decided to take the next leap, which was to start 3D printing our surgical guides in office. Again, if you're going to do this in office, the Blue Sky software makes it very easy. It's really the only alternative out there at this point that's cost effective enough to use in office. The software itself is free to use. You can even design the surgical guide in the software. And when you export the guide to the 3D printer, that's when you get charged. The cost is about $15 for the export. of the guide to the surgical, to the 3D printer. So in Hugh's case, we planned the implant placement in the software. We decided to fabricate the guide using the 3D printer. And I'm going to show you Hugh's implant placement. This is actually the actual surgery using a guide made on the robots printer. We're going to let the video play here. You can see the first thing we're going to do is actually open a flap. This case could be done flapless. A lot of times when we're teaching at our program, our implant program, we will lay flaps because every case that we do at our course now, we're doing guided, but we still want the doctors to experience the surgery, to experience dealing with the soft tissue, dealing with the bone. So you can see we have a successful bone graft there. The bone looks really good. We've placed our surgical guide. This is a surgical guide printed on a Robox printer. And now we're going in and drilling the site. This is a Biomax implant. It's one drill. We'll go ahead and make sure there's a lot of irrigation as we drill the site. One of the things you have to do have to be careful about when placing implants using surgical guides is that there's enough irrigation getting to the drill. So you'll see we'll come in with a little bit of external irrigation with a syringe as well, not just from what's coming off the handpiece. Also, there's a lot of bone coming on that drill, and we actually will collect that bone. You'll see a little bit later on how we can use that bone to our benefit. So we're going to go ahead and irrigate the site and continue drilling. In this particular case, it's just one drill. And now we're ready to place our implant. We'll irrigate the site with sterile saline just prior to placing the implant. And then we'll do the final torquing of the implant with a ratchet. You can also make an implant placement guide. I prefer not to use it. A lot of times there are clearance issues to get the guides into the mouth and such. Also, I find it a little bit faster just to place the implant freehand. But there are some consequences to that, and I'll mention that in a minute. So as you can see, the implant is now placed. We will actually take some of that bone that was harvested. We'll store it in a dappen dish, and we'll actually use that. You can actually see the implant here. We're placing the cover screw now. But going back to that bone, we'll harvest some of that bone and keep it off of the drill, just in case. Because in this case, I decided that we were going to place a little bit of bone to enhance the buccal dimension of the area of the anatomy. Didn't need it for the implant to integrate, but we just wanted that area to be a little bit wider for a better profile when we make our final crown. And then we'll go ahead and put in a couple of fibrochromic sutures. Very simple to do to hold that tissue back in place. And in 4 months, we'll go back and uncover this implant. So I'm just going to try to move ahead here with this video. I guess I have to let it run. So
there's a question that came in. Why did you irrigate before placing the implant?
Well, you know, we're in and out of the mouth. The tongue is getting in there. There's certainly bacteria. It's something that I just do because of habit. Not sure it's absolutely necessary, but it's just something that I tend to do. I like to flush the area out, make sure that we get as much bacteria out of the site as possible just before we place the implant. Also, if there's any soft tissue that might get caught in there, I like to have a clean osteotomy before we place the implant. Okay,
there's another question a little bit off topic for now. Is there any evidence-based dental study to compare between different CBCT machines?
There are lots of studies I've seen, the only conclusion that I can draw from this is that from all the literature I've seen is that the newer CVCT units tend to be a little bit more accurate than the older ones. Other than that, you know, CVCTs are very, very accurate. There was a recent study that I saw in the Blue Sky Forum, and I think Sheldon Lerner talked about this as well, where they compared CVCT to medical scans, and they were using fiducial markers. And I came basically to the same conclusion that he did, which was that they were using an older CVCT unit that showed a very small difference. But I would say that in general, most of the CVCT units on the market today are very accurate, and we can certainly rely on them for our surgical guide planning and fabrication. So here's the implant immediately post-op. You can see it looks pretty good. Of course, this is a two-dimensional X-ray. So let's see how we did. I'm gonna have to pause this for a minute to keep going here for some reason. So let's see how we did. What you're seeing here is an overlay of the actual implant placement. This is an immediate post-op CVCT. The white that you see there is the actual implant in the patient's mouth. The red is where we had planned to place the implant. So you can see our guided placement was extremely accurate. The only difference that I can see in this image is that I did not place the implant as deep as where we had drilled the osteotomy, where we had planned it. And you can actually see that the osteotomy was drilled according to the plan. I just chose to not place the implant quite as deep based on my visual reference when I placed the implant. Here's an axial cut showing the same implant. The white is the implant. The red outline is where the implant was planned. Extremely accurate placement. Here's another case. This is Shania. Shania is also post orthodontic treatment. Very tough case because the orthodontist actually didn't leave us enough room here, and the braces were already off in her case. Did not leave us enough room here for two implants between the premolar and the canine here. So this was a very challenging case. And I want to show this case because it illustrates how accurate our guided surgery can be. So in Shania's case, we decided to place 3 implants, 2 in the premolar space and 1 back here in the molar area. This is the plan in the Blue Sky software. These are what the implants look like on the 3D rendering. We printed the guide on our Robox printer. Here is a guide in place. We're drilling the osteotomies, and we then visualize our osteotomies and place our implants. So again, these implants look very close, especially on a two-dimensional image. You can see that the distal implant it looks like it's right smack dab in the middle of the space. The mesial implants, especially the most mesial implant, looks like it's very close to the root. But if you look at it on a slice from a CBCT, where we've drawn in a cross-sectional arch, you can see that the implants are actually quite distant from the roots of the teeth. And we can even do the similar overlay. Here's a video overlay of where we had planned to place the implants. These are the 2 mesial implants in the premolar space. The green outline, which you see there, is where we had planned to place the implants. And the white is the actual implants from an immediate post-op CBCT. The 2 images can be overlaid, and you can actually check the accuracy of your guide. So here's another video showing now an axial view of the 2 mesial implants and then the distal implant. Now you can clearly see that the distal implant is off. It's off by about a full millimeter. What do we attribute that to? Well, one of the problems with guided surgery is that if you're not using an implant placement guide, in soft bone, sometimes the implant can move. And that's exactly what happened here. My angulation as I drove the implant in by hand was just slightly different. Why didn't this happen as much on the two mesial implants? There was denser bone there. I could actually feel this distal implant while I was placing it move because the bone in this area was so soft compared to the thinner, denser bone on the premolar site. So just because you're using a guide doesn't mean your implants are going to be placed exactly where your guide says they're going to be placed, especially if you're not using an implant placement guide. Now, I don't routinely use an implant placement guide, but I plan my cases with enough leeway that, to me, this is an acceptable position for that molar implant as well. And then we can look at this also from a 3D rendering point of view. This is a video where we can strip away the bone, overlay the pre-op plan, which was the red, with the post-op actual implant placement, and you can see how accurate our guide was, especially on the two mesial implants where the bone was a little bit denser than in the molar site. And again, I attribute that being slightly off because of the soft bone. As I drove the implant to place, I could actually feel that I could change the position of the implant with the hand driver as I was putting it in. But still, very acceptable position. So I want to share one more case, excuse me here, before we move on to some of the more into 3D printing. This is Patricia. Patricia came to us for a full arch reconstruction, and because of finances, Patricia decided that we were going to have to extract the anterior teeth. We convinced her to save the posterior teeth for support back there to keep her vertical open. But because of finances, we had to extract the anterior teeth. We did do some bone grafting in case she changed her mind and wanted to have implants placed in the future. So this is 4 months later. We do a CBCT scan, and we actually convinced Patricia to have 3 implants placed in the premolar areas to attach locators, because her plan was to have a partial denture. So that's what our initial plan was. We went ahead and planned this in the Blue Sky software. You can see here we designed a guide and fabricated a guide. And we went ahead, this is a guide being printed on the Robox printer. And these are basically the steps that we went through, all the different images, and we actually placed the implants using the guide. The cost of this guide to fabricate materials and the sleeves and everything was about $35. So we were able to place these 3 implants, again, for locator attachments, using the surgical guide. We had good osteo readings. You can see the accuracy of the guide. We laid a flap so we could, again, judge the accuracy of our guide. And we were able to place the implants very accurately using the surgical guide. Now, something happened during this time period that Patricia had to wear a temporary partial denture. She changed her mind about having a removable appliance and decided that she wanted something fixed. She decided that she just could not tolerate wearing a partial denture. Even though we had promised it would have better fixation with some locator attachments, she decided that she wanted to have something fixed. So we had already placed 3 implants, and now she decided she wanted to have something fixed. We went back to the treatment plan and added a couple of implants. This was very easy to do in the Blue Sky software, and it was very easy to redesign the guide and then export that and print the guide. We actually printed the guide. I don't have it here to show you. We printed the guide and used it to place 2 additional implants, because by adding 2 additional implants, we could give her a fixed restoration on 5 implants, and that would satisfy her requirements. Now, what's interesting about this is because we had done all the treatment plan and the merging of the DICOMs with the STL already, we were able to do this very rapidly and output a guide. We didn't have to treatment plan the whole case all over again. All we had to do was add 2 implants and spit out another guide. And by the way, the Blue Sky software doesn't charge you for additional guides. So we had already paid for 1 guide. There was a $15 STL export fee, and we could do a second guide at no charge from the point of view of the cost of the software. Of course, we did have to buy sleeves and such, and then we were able to do this. Now, as I'm prone to be, I'm a procrastinator, and one of the things that that we did was, we had Patricia on the schedule to have her implants uncovered. We did this as a 2-stage surgery, and I couldn't remember where we had placed those implants, and we had misplaced the original guides we had used to place the implants. So here's a little tip for you. You can make what I call an implant uncovery guide for about less than $1 using a 3D printer. We were able to actually spit out another guide from the 3D printer. You can see the sleeves are not here because I'm not going to be using the sleeves, but this actually brings me back to the exact location of the implants, and by making a small incision just off to the lingual or the palatal, we're able to find our implants very quickly, uncover them, move some of the keratinized tissue, as you can see on the 2 anterior implants, to the buccal, and allow for more keratinized tissue. So there's a tip for you, what's called an implant uncovery guide. If you've misplaced your original guide and you did the case with a Blue Sky software, you can spit out another guide to a 3D printer. We took this technology and this what we were doing to a very advanced level, in that we actually used these models that we were making to create sinus window guides as well. Here's one of the guides that we used, and what we found was it's best to actually leave an opening so it outlines the inferior part of the lateral window, and it allows us to place our window very rapidly without having to figure out exactly where the height of the bone is and such. So this is something that we use from time to time, another technique that you can do, a sinus window guide. I've actually asked Blue Sky to look into adding this to their software. Hopefully at some point they will as well. So just real briefly, this is the workflow that we use in our practice. When we're making these 3D printed guides, we do a clinical exam, we acquire the data, the CBCT, impressions, bite registration, we mount the mount the models and do a wax up typically, because every case that we plan is from the prosthetic point of view. We'll scan models using an optical scanner. We do have an optical scanner in our office. I'll talk about that in a minute if you don't have an optical scanner. We plan the case in the software, we design the guide, and we 3D print the guide. So I mentioned before, in order to use this technology, you need to merge a DICOM image with an STL file. And typically your STL file traditionally has been coming from an intraoral scan. But if you don't have an intraoral scan, there are ways of creating an STL file. It is absolutely important to have a CBCT. You cannot do any of this without a CBCT, but you can do it without an optical scan. And several people have developed techniques of scanning stone models, for example, such as Corey Glenn. If you want to see and learn how to do this, to create an STL file from a stone model, you can go to YouTube, do a search for Corey Glenn stone model CBCT, and he's got a great video on how to do this using the Blue Sky software as well. So one of the more recent developments is something that I developed called a digital pour. It's great to be able to scan a stone model, but to make to streamline the process even more, I decided to experiment with taking a CBCT image of an impression using just standard VPS impression material. And we actually figured out how to reverse the image using free software in what is now known as the Ferguson digital pour technique. So we're able to bring this image, the CBCT image of the impression, and bring that into the Blue Sky software, reverse that image into an STL model that then we can design and fabricate a guide on. This functionality will be available completely in Blue Sky software in the next few weeks, I understand. I asked Blue Sky several months ago to, I showed them what we were doing, and I asked them to build this functionality into the software. Previously to that, though, we were doing this, and we still are doing this until the new release comes out, using different software. So the first step, and I'll run through this, it's going to take about 2 minutes to run through this video, where we load a DICOM of a BPS CBCT scan into the Blue Sky software. So here we already loaded the DICOM of the patient's jaw scan into the software. And we're now going to be loading into the software as a scan appliance. Blue Sky software has this functionality to bring the CBCT of the impression into the software. And this is not going to reverse the image, but it allows us to get a solid image of that scan. We arbitrarily place that in the software, and then we can export this. Just export it as an STL file. So we call this impression scan from Blue Sky Bio. We bring this into another software called Mesh Mixer, which is a free software, by the way. And because shell files are hollow, we can actually delete the outer shell, exposing the inner shell of the file, in the image, deleting that section away, and that gives us the reversed image. There's an additional step to go through to actually make this a reverse image, and there we just did that. We can then bring that back into, save that as an STL file, import that back into the Blue Sky software, and now we have a reversed image, and that we can now merge through our standard merging technique of using points. You'll see that in a second here. Matching points and merging the two files together so that we have a clean image on which to create our surgical guide. So here we are matching our points. And once the points are matched, we can check that in the software. I think we had to do one last point here. And you can see that the merge was fairly accurate, as indicated by the green outline overlaying the CBCT image. And then we can use that and plan our implant and then fabricate our guide on that image. So I consider this a big step because that eliminated the need now to have an optical scan. If anybody wants to see the full video is available on YouTube. Do a search for Rick Ferguson Digital Pour, and you can see that as well. Now, several other doctors, including Corey Glenn and Hiroshi Takagi, have videos as well on how to do this using my original technique and modifying it. I've also developed a technique called a dual scan inverted denture tissue supported guide using the Blue Sky plan software. That's available on YouTube as well. So let's go back to 3D printing. Let's look at this Robox printer. This is a printer that is actually now available. I brought this, I informed folks at Blue Sky about this 3D printer. They looked into it. This is not the first 3D printer, as I said, that I've used, but I felt that this printer had the ability to really enhance the implant practice because of the quality of the printing, because of the ease of use. One of the things that this printer has that most 3D printers don't is it has a cartridge, a reel of filament It's a filament-based printer, but the reel has a chip in it that keeps a track of how much filament is being used. It has things such as a flow rate measurement that informs you if the print if the filament is flowing properly. It has a very high resolution. It can print down to, according to the manufacturer, 20 microns. I would say realistically 50 microns, but that's certainly enough to print surgical guides. So I brought this printer to the folks at Blue Sky. They looked into it and they actually decided to start carrying it on their website. So it's now available through the Blue Sky website. This is a phenomenal. I have actually 2 of these printers in our practice. So how does this printer work? What is this 3D printing technology all about? Well, what you see here is a nozzle of the printer spewing out a plastic resin material. Now, the resin we use is a copolyester. It's a food-safe, FDA food-safe material. What you're seeing here is layering. 3D printing is actually, in my opinion, a misnomer, because what 3D printing is actually 2D printing layered. So you have these layers of material that are built up slowly over time to create a 3-dimensional object. So you're seeing this nozzle that is about 0.3 millimeters in diameter. So this bead of material that's coming out is 0.3 millimeters in diameter, supposedly, and that should give you a level of accuracy. Well, actually, you can get a higher level of accuracy than even, and this is a question that I get from time to time, is what is the accuracy of this 3D this 3D printing technology, the filament technology? Well, through a very sophisticated system of the computer calculating the flow rate and the speed of the nozzle, we can actually get a higher resolution than 0.3 millimeters. Now, typically we're printing at 100 micron, which is 0.1 millimeter. So how do you get 100 micron from a 0.3 millimeter nozzle? Well, as most dentists can appreciate, what you're looking at here are 2 beads of impression material. The one on the left is certainly thicker than the one on the right. Yet they were created with the same nozzle. How is that possible? Well, simply, we flowed the material, the one on the left here, we flowed the material at a slower rate than the one on the right. Both of these beads of material came from the same nozzle size, right? But because we were flowing them at a different rate, we're able to create a smaller bead. And that's how these 3D printers are able to print at a higher resolution than even what their nozzle says. This is all done in the software in the 3D printer and the software that drives it. This is not something we have to necessarily be concerned about, but I do get questions from time to time about how we're able to achieve a higher resolution than the nozzle size of the 3D printer, and that's how we do it. This is actually a guide I printed just yesterday. This is the level of accuracy we can get from the Robox printer. It's not the only 3D printer out there, filament type printer, that can give you this level of accuracy. But again, going back to the ease of use, the automatic bed leveling, for example, with this printer, the built-in calibration systems, I feel that this is, the size of the printer itself is very, very small. It's something that fits on your desktop. It's no bigger than a laser printer. Actually, it's smaller than a laser printer that I have it sitting next to in our office. But this is a guide that we're able to print. Now, anybody familiar with filament printing knows that that one side will always come out more accurate than the other. And what we do is we actually print our guides upside down. So the side, the intaglio surface of the guide will always come out very, very accurate. That's why we print them upside down. So what we have to be concerned about is this flat section here where the sleeve will fit. Now, with the Robox printer, I've actually worked out some custom settings that allow us to print with supports. There's a support piece that is printed that supports this flat section right here that breaks off after the print is done, that allows us to get this level of accuracy. Of course, this is magnified. That allows our sleeve to then snap in and fit very, very accurately. We're actually printing these guides with the hole 0.05 bigger than the sleeve, which is a very, very high level of accuracy, so that when we print them, the sleeves will actually go in. You actually have to print the hole just slightly bigger than the sleeve, or else you'll never get them in, whether with this type of printer or with an SLA printer or a more expensive dental printer. So we're able to print these with a very, very high level of accuracy, and you can see. Now, you'll notice that there are some rough spots where the filament is threaded a little bit. You can clean those up using these polishing brushes, which you can get from Dentistry. I prefer this black one, which is the medium quality. This is what they look like in the package, so those are available. We use these to polish up our guides sometimes, and this is what one of the guides looks like polished. I did get a question yesterday before somebody submitted a question for this webinar, is can you print full arch edentulous guides using the Robox? My recommendation is no, is not to do that. Not because the accuracy will necessarily be off, but the problem is a lot of times when you're printing full arch guides, the trajectory of the guide holes, especially if you're doing lateral pins, will be in such a way that they don't print accurately. 3D printing is a little bit of an art. We have a technique where we can print tooth-supported guides very accurately in the same position every time, and we have a course that we teach on this. But this is what you see here is an anomaly. My recommendation is to use the Robox printer to print tooth-supported guides only, and for full arch guides, either outsource the printing, which I'll talk about in a minute, or buy a different level of printer. So how accurate is this printer? You can go to websites and download STL files that allow you to print calibration cubes, and we do this routinely from time to time, maybe once a month, to check the accuracy of our printer and run a calibration routine if we need to. And this is a 20 millimeter calibration cube, so it measures 20 millimeters in all directions. You can see here with the calipers, very high level of accuracy, 19.99, 20.00 on the X and Y, and as far as the accuracy of this printer. Now, what about full arch guides? And what if you want a higher level of surface detail in your guides? The next level of printer that I would say that can do a very good job is the Formlabs printer, and they actually have a dental resin. They released about a month ago to great fanfare. We actually purchased one, and we've been experimenting with it. So first we tried to print just like we would with the Robox printer, and we weren't very happy with the results. This is what happened in the flat area where the sleeve needs to sit. You can see there was a concavity there, and when we tried to seat the sleeve, there was a gap. Now, does this matter clinically? I'm not sure, but what we had to do was we had to experiment and come up with different ways of printing. When we found that if you turn the guide at an angle like this, then it tends to print better. This is what's called an SLA printer. It uses a laser photo curing type of resin. This is the Formlabs dental resin. You can see it has a much finer surface detail as far as the finish of the surface. This is printing at 50 micron. The disadvantage, though, of printing in this orientation is that it takes about twice as long. So a guide like this will probably take about 3 hours to print. You can see the support structures that you then have to break off. And there's a cleanup time as well, which will take you about 20 or 30 minutes after the print is done to do the cleanup process. You can look online and learn more about that. Overall, we're pretty happy with the printer, but it has not replaced the robots as far as our day-to-day surgical guide fabrication. I do think for full arch guides, though, this is a better printer because the guide holes will come out a little bit more accurate, especially if they're lateral guide holes. And you can also, with their software, determine on your own and change the placement of the support structures so that it doesn't interfere with your guide sleeves and your guide holes. So what about the level of accuracy with this printer? You can see here we got 19.93, 19.98. The numbers tended to actually be a little bit smaller with this printer, but again, you're talking 0.03 and 0.02 millimeters. Very, very small discrepancies. It could just be in the caliper that there's a discrepancy in the caliper as well. So very high level of accuracy, and you can see how you're able to do this printing. I'll show you this quote from one of our students who took our 3D printing course and bought a Robox printer. This is Dr. Kurt Bally. He's from South Florida as well. He says, "I'm very happy with adding this technique to my practice and will be using it on all upcoming implants." So literally, here's a gentleman who came to our 3D printing course, took it to the next level, and now he's doing all of his cases guided as well. I'm going to address another issue that I get from time to time is as far as the materials that we're using with our 3D printing. The Formlabs printer does have what they call biocompatible resin. It is much more expensive of a printer, and of course the resin is a lot more expensive as well. A liter of the resin for the Formlabs printer is about $400 compared to a reel of the filament for the Robox printer, which is about, I think it's about $40 on the Blue Sky website. You'll get about the same number of guides from each one. So it's going to cost you probably about $15 to $20 to print a guide with a quadrant guide with the Formlabs printer versus literally less than $1 with the Robox printer. The Robox printer uses an FDA cleared resin, which is approved for food safety. Now we have to consider that surgical guides, dental surgical guides, are what are known as Class 1 medical devices, which are the lowest risk factor for medical devices and are subject to the least amount of regulatory controls. An example of a Class 1 medical device is dental floss. Of course, we're familiar with dental floss. It's a device, if you look at the FDA website, surgical guide is a Class 1 medical device because it's meant to be used in the mouth for less than an hour, as opposed to a Class 2 medical device, which carries with it a greater amount of regulatory control. And you can see this from the FDA's website that condoms are classified as Class 2 medical devices. So, I did a little bit of research. I looked at this and I said, well, that's interesting. Dental floss is a Class 1 medical device, and condoms are a Class 2 medical device. What I took away from this is that if you're using your surgical guides in the mouth for more than an hour, or you're using your condoms for less than an hour, you're actually misusing them according to the FDA. I can hear the laughter reverberating across the internet right now. But of course, that's a joke. But consider that we're using a Class 1 medical device subject to the least amount of regulatory control. I'm going to leave you with with one more case and a tip. Plan and execute every implant case with CBCT data, because you don't want to end up like the dentist who placed this implant. This is a patient that ended up in our office for some implant revision surgery because she was having some inflammation around this implant. Avoid this from happening in the first place. This implant was not placed with a surgical guide. So let me introduce you to Mo. Well, this is our last case we're going to look at today. Mo is in his 60s. He presents with a fractured tooth, fractured off at the gum line. His previous dentist had temporarily re-cemented it and told him he needed to have the tooth out and have a 3-unit bridge or an implant placed. He came to us for a second opinion. We did agree that he needed to have the tooth out, and we did agree that an implant was probably the best way to replace the tooth. Mo did not want to have his natural teeth shaved down, and I actually thought he was a good candidate for immediate placement because this this crown that he had on here was just temporarily re-cemented, yet he had not knocked it off. I was really surprised about that. So I felt like he would be a good candidate to be very gentle with an immediate implant placement with a restoration. This is what his x-ray looked like. The post was actually fractured completely off here horizontally, even though it looks like it's still attached, this x-ray. So this is what it looks like from the lingual or the palatal. So what we did with Mo was we went ahead and gathered our data sets. We got our CBCT image, we got our scan, an optical scan in this case. We digitally extracted the tooth. We planned the implant using the temporary crown, the crown temporarily cemented for the implant position. We digitally extracted the tooth, and then we went ahead and designed and fabricated a surgical guide in the Blue Sky software. We then printed that surgical guide. That's not the same surgical guide in the picture, but we printed the surgical guide in, let's see what happened here. Oops. Lost my image here for a second. We printed the surgical guide on the Robox printer, placed our metal sleeve, and then extracted the tooth. And in this case, we actually used a piezotome to extract the tooth as atraumatically as possible, leaving the buccal plate intact. We placed our surgical guide, drilled the site for the implant placement. Here's the implant placement. I took this picture to show that we're not up against the buccal plate. We usually like to leave 1 to 2 millimeters between the implant and the buccal plate for native bone to grow in. We do put bone graft material in there. We've got an Ostel reading, very high Ostel reading in this situation of 71. So it told us that we could immediately load this implant. We fabricated a temporary crown using a shell crown, and we placed the temporary, and Mo went home with the tooth. The suture that you see here wasn't absolutely necessary. I actually pulled the tissue to the buccal just so I could get the picture. It's not necessary to actually reflect a flap in these situations. But because I had pulled the tissue so far to the buccal, I decided to put in a couple of 5-chromic sutures. But again, to me, this is the epitome of implant dentistry today. That somebody can walk into a dentist's office, have a tooth extracted, and immediately replaced with an implant and the temporary crown. This is what we should strive for. But how accurate is this? I want you to take a look at this image. This is a video showing the immediate post-op CBCT scan of the implant placement. And I want you to look at this concavity right here. We'll run through this video again one more time. You can see that there is a concavity in the bone just distal to where the tooth was, just distal to. That is a very deep concavity, yet we were able to nail that implant placement. Also, look at the incisive canal. That implant needed to be very precisely placed. And we were able to nail that implant placement using an in-office fabricated surgical guide. This, guys, is not Rick Ferguson. What you're seeing here is the technology. I could not have done this implant placement as accurately freehand. Even with 20+ years of implant placement experience, This is something that only technology can afford us. Look at the position compared to the root of the tooth number 8, just slightly to the lingual so that we can make a screw retained restoration. Amazing. So I'm going to leave you now, but before I go, I want to show, just to let you know that we are having some courses upcoming using on how to use this technology, how to do the 3D printing. We have a course coming up Friday, July 15th in Orlando. That course is almost full right now. And then we have another one September 10th, which is going to be held in Fort Lauderdale. We're going to actually do a live surgery at that course using a guide we fabricate. And at both of these courses, we will have both 3D printers, both the Robox printer and the Formlabs, and we'll teach you how to use both of those printers. We also have an upcoming course taught by my colleague, Dr. Dwight Pate, at Knight Dental Group in Tampa. This course is not going to be about 3D printing. Knight will do the 3D printing for you as well if you don't want to get into the 3D printing part of it. Although I tell you, it's not as difficult as you might think, and it's actually quite a lot of fun to do. But Dr. Pate will be teaching the Blue Sky software at this course, not the 3D printing part of it. And then you can outsource the 3D printing if you're not interested in doing it yourself to a lab like Knight Dental. There are also several other companies now, other laboratories that will do the 3D printing part for you. Here's my contact information. drferguson@aol.com, implanteducators.com. Please go there and see what other course offerings we have. And here's some other information about implant educators as well, and myself. I want to, again, thank Blue Sky.
Wait, Rick, before you sign off, can I throw some questions your way?
Absolutely. Absolutely.
Okay. First of all, how much would you approximate is the cost of a surgical guide printed on the Robox printer, all inclusive?
All inclusive, let's say it costs you $15 for the export file, export fee. Of course, that's a variable cost based on the number of exports that you buy from Blue Sky. Let's say $15 to print the actual guide, $1 to $2, so that's about $17 right there. You do have to buy the sleeves. The sleeves will run you anywhere from $5 to $10. So let's say high on the $10 side, depending on where you buy them. They are available from Blue Sky, I believe, for about $6. So you're up about $25, $27 total cost. You know, so not bad at all. And now we do actually reuse the sleeves, so that's one way to reduce the cost. But still, you know, for a lot of things that we do in dentistry, this is ridiculously cheap. And with the level of accuracy we're getting, I think if you are inclined to do this, certainly come and learn it. We will show you how to do it, and it's a lot of fun. So that's with the Robox printer. If you're going to the Formlabs printer, for example, you can probably double that cost.
And how long would you say from start to finish, from the CT scan until you have a surgical guide in your hand? How long would you say that takes?
We've done it in as little as 2 hours, about 30 minutes of actual software planning time, and about an hour and a half or so of printing. That's with the robots. Now with the Robox, the guide is ready for use immediately. Now you do have to cold sterilize it, but you know, the guide is ready for use immediately. With the Formlabs printer, there's about another 30 minutes of post printing processing that has to go on. There's an oxygen inhibited layer that needs to be removed, and then it could be as much as another 2 hours, because I forgot about the post curing that you need to do with a special UV light, as well as moving the oxygen inhibited layer. Certainly Formlabs gives you instructions on how to do that. We've actually, in our course, we'll be teaching a few ways to shorten that time tremendously, using some tips. So, you know, some things that we've worked out. So that's with the Robox printer. I'd say the fastest you can probably get it done is about 2 hours. With the form labs, you're looking at 3 to 4 hours, but still, certainly within a day.
Okay, and you could export just a question that came in. Does the Robox accept the STL file exported from the planning software for printing?
Yes, there are a few steps that I do recommend you do with the file directly from the planning software, the Blue Sky software. You could import it directly into the Robox, but there are a couple of little steps, and I actually have a video on that as well that we give to our students at our courses. It also includes my custom, that video also includes my custom settings for the Robox that will give you a very high level quality of printing, a little bit better than what the manufacturer even was able to do, just through our own research and experimentation. That video is available if you contact me for $150. It shows you how to position and the guide. Remember, with Robox, I'm recommending 2 supported guides only, but it shows you how to position those guides and how to actually modify the guide file, the STL file from the Blue Sky software. And if anybody wants that video, they can contact me at drferguson@aol.com for purchasing that video. Otherwise, yes, you could directly print from the file created with the Blue Sky software. The software that comes with the Robox I showed you, it's called Automaker. It's very, very easy to use. It's very visual. You basically drag and drop the file, STL file, onto what looks like the printer bed, and you just basically once you put in the initial settings, especially if they're my custom settings, you just hit print.
Okay, please comment on the use of pre-made provisionalization in conjunction with guided surgical guides, especially in the aesthetic zone.
I assume when the questioner asks about pre-made aesthetic restorations, we have not had good success with those at this point. You know, I don't want to say that other people haven't. I just don't have. I won't say, because we just have not had. We haven't done enough of them to say whether they're that good or not. We have had some issues with some of the ones we've tried where we, tried using the guide to place the implant, but have also had a custom abutment and temporary crown made ahead of time. They just never. It could also be the fact that because we have so much experience placing implants freehand, our implants don't necessarily end up exactly at the same vertical level as where we plan it sometimes. Let's just put it that way.
Okay. Do you routinely take post-placement CBCTs?
That's a good question, and I would say with guided surgery today, you don't have to. Understand that a lot of the cases that we're doing, we're documenting for training purposes, for teaching purposes. So we do pretty much all of our cases, we will do a quick CBCT at the lowest level of radiation that we can. I'm not that concerned about radiation level, if that's the impetus of this question, because our CBCTs today use such low levels of radiation that it's actually less. For many years we used a film-based Panorex as our primary modality for assessing our implants post-operatively, and we didn't hesitate to take a post-op Panorex. Yet our CBCT is using actually less radiation than our film-based Panorex was. So I'm not concerned about the radiation, and if there's any question at all, I would say go ahead and take a post-op CBCT before the patient leaves the office. But we're finding such high levels of accuracy with our surgical guides that it's really more so for pacifying the doctor, I would say, than actually any medical necessity to take a post-op CBCT. And of course, again, we are taking ours a lot of times for training purposes.
Okay. Have you noticed any significant differences in results between using the impression technique with a CT scanner versus importing an STL of the model and creating a surgical guide that way?
I have not found any difference as far as the accuracy. There are a couple of reasons I can speak to that for. It is that, first of all, the software is going to be building in a die spacer basically around the model. So when you actually create the surgical guide in the Blue Sky software, there is actually a 0.2 millimeter die spacer that's built in to allow the guides to fit. The software is also going to be removing any undercuts on the models. The other thing, though, is that you need to do an assessment of the accuracy. Take some scans of if you're doing an impression or if you're doing a stone model scan, take some scans and assess them with the accuracy of an optical scan of that same model to work out the settings that will work best for your particular setup. Okay, you can overlay the two images and you'll see the outlines in the software. So that's my recommendation. Corey Glenn has a great video on YouTube on how he did it with his CBCT machine. There are several other folks out there who are looking into that as well. We have a setting that we find works very well, and I would say that the level of accuracy should be not much different. But remember, you know, surgical guides do have some discrepancy. If you ask any guide manufacturer to guarantee their surgical guide, they won't. They'll tell you that surgical guide could place the implants to 1 millimeter or 1.5 millimeters from where you planned it. So you have to understand the level of accuracy and build that into your treatment plan. You know, when we plan, when we're near anatomic structures, you know, there's this long-standing 2 millimeter rule. Just because we're using guided surgery doesn't mean that we violate that 2 millimeter rule. And check yourself each step of the way.
Okay. How do you recommend supporting and positioning the impression during the CT scan? And I'll follow up with that saying, what kind of hints or tips do you give in terms of creating the impression for the CT scan?
Okay, well, it's important that the impression not have any thin areas in it. So going back to dental school, remember, you know, you wanted to have an even amount of impression material all the way around the teeth. So especially in the canine areas, for example, you don't want to seat that tray all the way down to where the teeth touch the tray. The tray itself has a lower density than the actual VPS impression material. So one of the tips is make sure you have enough thickness of material all the way around the model or the teeth that you're impressing. So sort of go back to your dental school training on that. And the second thing is you want to position the tray, the impression in such a way that it's not directly on the bite block of your CBCT. Of course, every CBCT is different, but you saw in the picture that I showed earlier, we basically place it on a foam pad, the kind that come in your lab cases. You know, so that's how we do it. I'm sure you can make custom, a custom tray for that or whatever you want to do, but I haven't found that to be necessary.
Okay, one more question, I believe. What kind of, you presented this technique in the process flow, what kind of cases, and you already mentioned the edentulous, are there any other cases to stay away from, be careful of, not to use this technique for, or any other warnings that people listening to the presentation should keep in mind before they go in and do this themselves?
Well, we haven't found, other than the fact that if you're going to be printing Robox guides, I would say using our techniques that we teach at our course, I think we can safely say that you can do any partially edentulous case with that type of technique, which is probably 80% of your cases. If you're doing full arch edentulous cases, there's certainly a lot of educators online, and I even have a video on YouTube how to do that as well. But again, I would probably go to a higher level of printer than the Robox for fully edentulous cases. And again, keep in mind that, especially if you're using tissue supported guides, give yourself some leeway, because there is going to be, that guide is going to be subject to the compression of the tissue. And again, I think Corey has a great video on that. His last webinar on that was as part of the series was actually quite excellent as well. As far as using our techniques, I would say, of course, be careful and check yourself each step of the way. This webinar tonight was not meant to be completely didactic. It was really just to showcase how we're using this technology, and I would highly recommend you come to our course to get a full training on using our techniques.
Okay, just two technical things before signing off. One is, please make sure to enter your details into the webinar attendance form. The links for the forms are under the video screens. The second thing is, the CE credits will be sent via email within around 1 week's time. Additionally, as Rick mentioned, we're going to be releasing a new version of Blue Sky Plan within a couple of weeks that will have a lot of this functionality built in, including the impression version. So stay tuned for the update and the new functionality inside. I think that pretty much wraps up tonight's presentation. I'd like to thank Dr. Rick Ferguson for giving the presentation, contributions to Blue Sky Plan, contributions to guide surgery, the research you've been doing and continue to do. It's very much appreciated, especially by us, and I'm sure by everybody else who's learning from you as well.
Well, thank you, Michael, and I thank everybody for listening this evening. Have a good evening.
Take care. Bye-bye.